What I'd like to do now, take a deep breath, and we'll go into asthma assessment, module 2. So this relates to establishing the correct diagnosis for your patients. So generally speaking, we define asthma as episodic airway obstruction, airway hyperresponsiveness, and inflammation of the airways. And first we look for a characteristic history, then a characteristic examination, and then diagnostic testing. Let's take these in order. Let's start with the history. So we look for episodic symptoms. So there are good days, there are bad days, to suggest that there's reversible airflow obstruction. So when we think about asthma severity, we think about people that might have mild intermittent asthma. We have people that have mild persistent asthma, and then moderate and severe persistent asthma. So if you have mild intermittent asthma, you might have symptoms during the day less than 2 times per week, 2 days per week, whereas the mild persistent have it more frequently. By the time you have moderate persistent asthma, you have daily symptoms and nearly, excuse me, continual or nearly continual symptoms with severe persistent asthma. You can see that there's a gradient of nighttime symptoms as well, and in reverse, the lung function, in particular the FEV1 and the peak expiratory flow rate. So normal lung function for the mild, kind of a moderate decrease, and a more severe decrease for the those degrees of severity, and same thing for peak flow variability. In terms of triggers, like what causes people to be short of breath or cough or have wheezing, well, the most common are things like furry animals, indoor things like dust mites, outdoor or indoor molds, cockroaches, and seasonally pollens. So this is data from a study in the New England Journal about asthma improvement with home environmental intervention and education. And here's when the intervention was done, and here's the next year, the follow-up year, and this is the maximal number of days with asthma symptoms over a 2-week period of time. And you can see here's the control. So by being in the study, everybody got a little bit better. And here's what happens with the intervention. So it actually made things a little bit better. People had a little less number of days with asthma symptoms by doing an intervention where allergens were mitigated or removed from the home environment. But I think you can also see that it doesn't have an enormous effect, but it is in a positive direction. What's also important is there's a very strong control effect here, and this is true for all forms of asthma. When there's clinical research done, there's a very strong placebo effect, 15 to 20%. Other common triggers include infections. We talked about viral infections. Some medicines, some people are really sensitive to medicines like aspirin. Smoke, exercise, cold weather, gastroesophageal reflux disease, and sinusitis. Very common medical triggers for worse asthma control. What about the characteristic response to medications? Sometimes the easiest thing to do is to try a medication and see if it makes people better. So the characteristic responses to asthma medicines might be bronchodilation, so dilation of that smooth muscle, and then also through allergen avoidance or using an anti-inflammatory medicine like corticosteroids, a decrease in asthma symptoms. So we call the medicines that bronchodilate symptom relievers, and we call the medications that address underlying pathology like inflammations symptom controllers. And they're called symptom controllers because people don't often feel an immediate benefit from the asthma controller, but with time, like a week or two, they'll notice that they have fewer asthma symptoms. How about the examination? Well, we look for diffuse musical expiratory wheezing. So it's important to take out the stethoscope, and listen in the back of the chest, and ask people to take a big deep breath, and while they're exhaling, take a very careful listen to exhalation. What you'll notice is that in people that don't have asthma but have normal lungs, when they exhale, you can barely hear anything, especially over the adventitial regions of the chest. But if somebody has asthma, you will start to hear expiratory noises, even just airflow at the more mild versions. And when it's more severe, you'll start to hear musical wheezing. And it should be polyphonic, multiple notes. If it's monophonic, just one note, we worry about one airway being obstructed by a foreign body, by a tumor, by tuberculosis, something like that. So, is wheezing helpful? It's this continuous musical sound over a period of time, and it's because of oscillation back and forth of the opposing airway walls. I mentioned we look for polyphonic as opposed to monophonic wheezing. If you hear wheezing on inspiration, we call that stridor, and that generally implies a central airway, a large airway is involved, and you can see that with very small changes, even just going from 8 millimeters to 5 millimeters, you can go from shortness of breath to an emergency with stridor and near complete obstruction of the airway. So let's listen to these three sounds, and let me know, raise your hand if you cannot hear them. What we're going to do is listen to the three sounds and see which one we think is wheezing. Here's the first sound. Oh. This is, unfortunately, it's not playing. That's a shame. Okay, can you hear that or no? Raise your hand if you can hear it. Now, okay, sorry about that, guys. We practiced it and it worked. I'm sorry, I don't know why it's not working right now. Well, in a moment, I'll try to take when I take the talk down, I'll try to find that for you so you can listen to it. But one of them is showing just normal sounds. The next is inspiratory crackles or ralls, and the third is wheezing. And I'll try to get that in just a minute for you. All right, diagnostic testing. So this is done by something called pulmonary function testing, and we're looking for variable airflow obstruction over time on expiration. And this improves generally with a bronchodilator, and if we need to, we can induce it by provocative stimuli such as methacholine. So this is to try to capture this notion of episodic airway obstruction. This is what a flow volume loop looks like, and an obstructive pattern specifically. So expiratory flow is north, inspiratory flow is south over the baseline. So take a big deep breath in and blow out as hard and as fast as you can, and to keep going, keep going, keep going, keep going, and then take a deep breath in. So the peak expiratory flow rate is here, and a normal breath for this individual would be to connect the dots here. And you can see that this has come down more rapidly, and it has something that we call expiratory coving, this curved structure to the flow volume loop on exhalation. And this person gave a really good try. They went 8 seconds breathing out, and they didn't really plateau as well. So that suggests obstruction to airflow. So assessment of lung function by spirometry we usually do before, and then if it's abnormal, 15 minutes after we give albuterol, a bronchodilator. We use this to document reversible airflow obstruction. This helps with the diagnosis of asthma, and it actually gives patients immediate feedback. If we have reversible airflow obstruction, it's likely that the patients will have a nice response to inhaled corticosteroids as well. But if they don't have an immediate response to the bronchodilator, it doesn't mean it won't work, and that's important. So you want to encourage your patients with asthma to use their bronchodilators. All right, so here's a 22-year-old woman that we saw in clinic, and this is her data, her FVC, her FEV1, the ratio of the two, and her peak flow. And I think what you can see here is that her FEV1, as a percent predicted, this is the value, 1.4 liters, is lower than it should be. And when she gets albuterol, this is the value of her spirometry after albuterol, you can see it's increased by 16%. And what we do is we look for a positive response of a 12% increase in the FEV1 or FVC, and at least 200 cc increase. This is in liters, so it went from 1.4 to 1.63. So that's called a positive response. And you can see here in the solid line, that's the pre-response, and in the dashed line, that's the post-response. Here's the peak flow. So you can see that there was a reduction in the peak flow that improved And you can also see that the FEV1 went from here to here. So the peak flow rate monitoring, we can often do at home. These are relatively inexpensive plastic devices, and sometimes patients really get a kick out of following the numbers. I'm not sure if they're available in your practice setting, but if they are, these are often useful adjuncts to care. If we're looking for airway hyperresponsiveness, we're looking at bronchial challenge testing, and this is to help us detect airway hyperreactivity. Methacholine is the most commonly used bronchial challenge agent here, but frankly, exercise would do this as well for many patients, running up and down a set of stairs, for example. But we do spirometry at baseline, and then for methacholine, we give a graded increase in doses. And so we do spirometry repeatedly after each concentration. And the degree of airflow obstruction is present gives us some reflection of airway reactivity. If we give enough methacholine to all of us, healthy or not, we will all bronchoconstrict. So the hyperreactivity means they bronchoconstrict at lower concentrations of methacholine. Here's an example. Here's your FEV1 at baseline. You can see it's 100%. And here's the dosing of methacholine. And doses are given, spirometries repeated for each of these diamonds. And then when you get to a 20% decrease, going from 100% to 80% of the baseline, you can see that that's at a little over 6 milligrams per ml of methacholine. That is called hyperreactive, and that's because it's less than 8 milligrams per ml, which is our defined threshold. You can see here's an individual that decreased a little bit, but never actually decreased to 80% of their baseline. So this is a negative study. And and anything that's less than 8 is viewed as positive for airway hyperreactivity. So the concentration required to induce a 20% fall in FEV1 is called the provocative concentration 20, PC20, and that's what's reported out in the tests. And again, less than 8 milligrams per ml is hyperreactive. It's present in several people that are healthy that do not have asthma, so it alone is not enough to make the diagnosis, but it is highly characteristic of asthma to have hyperreactive airways. A negative challenge excludes asthma in most people, but it's important that it's done off medicines. And you can see that each of these medicines can have an impact, sometimes just for 48 hours, sometimes for 6 weeks on this test. So we use this when we suspect asthma and all the spirometry is normal. And when we try a bronchodilator in the clinic, it doesn't actually increase it because it's already normal. Patients can report things like a chronic cough or a nighttime cough or episodic chest tightness, somewhat atypical presentations for asthma, I would say. And this is when we start to think about using bronchial challenge testing. So for the third part of the definition, which is inflammation in the airways, one of the measures that we use here in Boston is called nitric oxide and exhaled nitric oxide. And we use a device like this to measure the amount of nitric oxide in exhaled breath. We also can look for eosinophils in the sputum, and sometimes circulating eosinophils can be helpful, and circulating serum IgE levels. Those are systemic inflammation, not necessarily in the lungs, but if the story fits, then I think that would be sufficient. So exhaled nitric oxide, again, we use it as an adjunct, and we think it's a marker of type 2 inflammation. The levels that we look for, normal is generally less than 30 parts per billion, and so anything over 30 would be viewed as a positive, an increase. And most of the time, this will respond to inhaled corticosteroids. Most of the time, steroids will decrease people's exhaled nitric oxide, reflective of less inflammation. So there are two domains overall when we think about assessing asthma control. One is how much the current impairment is. How does it affect people's quality of life, their functional capacity? How much symptoms do they have? Is it every day? Is it continuous? Is it a few days a week? How often do they need their bronchodilator for control? Is it limiting their ability to exercise? And then also, of course, importantly, what's the impact on lung function? But we also think about future risk. And this is about what's the risk for an exacerbation, a rapid deterioration in asthma control? And what about long-term loss of lung function? Is this going to cause people to lose lung capacity over time? Something we often think about is how much in the way of oral steroids do they need, prednisone and the like. Is it more than one course per year? That increases, that's reflective of a high future risk. So to summarize this portion of the talk on assessment and the pathobiology, asthma is a heterogeneous syndrome, reversible airflow obstruction, airway hyperreactivity, and airway inflammation. And the features that we think about more uniformly are that it usually begins in childhood, but it can affect everyone, all ages, races, and ethnicities, and gender. It's strongly linked to allergies, but it's not exactly the same. It involves allergic type inflammation, but in the lung, with mast cells, type 2 cells, T cells, and eosinophils. The symptoms are intermittent, and they're associated with airway narrowing that lowers your FEV1. But sometimes people can have, and this is quite common, normal or near normal lung function between the episodes. Generally, people are hyper-responsive, and this could be to allergens or even non-specific irritants, sometimes even just laughing or talking loudly. Blood eosinophils, serum IgE levels, and exhaled nitric oxide can serve as minimally invasive biomarkers for airway inflammation.